Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Peace upon all of you everywhere. You are all most welcome today in the Ziada Academy Zoom room meeting, which is conducting the all subjects about the anterior segment surgery, especially regarding the cataract and refractive surgeries. And I'm honored today to have the most experts and the most eminent surgeons in their fields. Honored and glad today to have my dear friend, Dr. Yassine Dawood, Associate Professor of Ophthalmology, Johns Hopkins University, United States. And he's a very eminent phaco surgeon, cataract and refractive too, and is a director of the phaco training programs in this university. Thank you, Dr. Yassine, for your participation.
Thank you so much for having me. I really appreciate it, and it's an honor to be with you guys today.
It's our pleasure. Also, I am honored and pleased to have my dear friend too, Dr. Ahmed Associate Professor of Ophthalmology in the University of Arkansas of the Medical Science, United States, and he is Associate Professor of Uveitis and Vitreoretinal Surgeon. So we will get a lot of benefits from him today about his great experience in the field of the posterior segment, anterior segment too, also the most difficult part of ophthalmology, which is the uveitis. Thank you, Dr. Ahmed, for being with us today.
Thank you so much, Hossein. Thank you so much, and I appreciate the opportunity. I'm delighted to be here with you all.
Okay, thank you very much. It's my pleasure. Also, I am honored to have my dear colleague and brother and the eminent vitreoretinal surgeon in our university, Al-Azhar University, Dr. Mahmoud Khaleel, is a lecturer of ophthalmology and vitreoretinal consultant in our university and in the International Eye Center too. Thank you, Dr. Mahmoud, for being here today with us.
Thank you. Thank you, Dr. Hassan. Welcome, Dr. Hassan. Welcome, Dr. Yassine, Dr. Ahmed. We are honored to be with us.
Thank you very much. And finally, I'm Hossam Ziada, the founder of Ziada Academy, and I'm hoping all the time to conduct meetings about the all subspecialties, especially the anterior segment topics, and spreading the knowledge and giving all benefits and all experiences coming from the all parts of the world to the all audience from my professors, my colleagues, and our juniors too. Thank you very much. I may ask Dr. Ahmed to start his presentation about the hot topic, the cataract surgery in diabetics. Please, Dr. Ahmed.
Thank you so much, Dr. Hussain.
Yeah, you are allowed to share your screen now.
Yes, 1 second. Okay. Right. Okay. So we're starting with the main topic of cataract surgery and diabetic retinopathy. We all, as anterior segment surgeons and retinal surgeons and comprehensive ophthalmologists, we all face this situation. Cataract, the diabetic patient, for example, with diabetic retinopathy and now having visually significant cataract. So what to do? So I've just put some points here for discussion. So the impact of surgery, we know that when cataract is visually significant and there's reasonable retinal function, then this patient would benefit from surgery. Also, there is an impact on visualization of the fundus to monitor retinopathy and macular edema. But then there are things that we need to keep in mind. And the question is, does cataract surgery cause worsening of diabetic retinopathy? And the other point as well, does it cause worsening of macular status or macular thickness or worsening of pre-existing diabetic macular edema? So these are important points really to consider. So maybe, I mean, Dr. Mahmoud is the retina surgeon here. So, Dr. Mahmoud, what do you think about diabetic retinopathy progression and macular edema? Does cataract surgery worsen this?
Yes, in many literature, it has been postulated that cataract surgery may worsen the diabetic retinopathy, especially if the patient has preoperatively diabetic macular edema, or especially if the patient has moderate to severe NPDR or further stage like Preoperative diabetic retinopathy. So it is postulated that it will make a progression in diabetic retinopathy post-operatively.
Right. So yeah, so that's that. So we did a recent review literature, maybe not very recent, a couple of years ago, and it seems that for diabetic macular edema or for macular thickness, cataract surgery does have an impact on the macular thickness, even modern uneventful cataract surgery. For diabetic retinopathy progression, the data is a little bit mixed. My take from this data that modern cataract surgery is unlikely to cause worsening of diabetic retinopathy, at least when it's not proliferative. Having said that, this needs to be treated with caution because there is data showing increased worsening. But for sure for the macula and maybe for the diabetic retinopathy, especially when it's really still not proliferative. Then again comes the next point for discussion, which is, okay, what preoperative consideration will we consider for cataract surgery? So there's the visual potential. Would this patient benefit from cataract surgery, or the cataract is very mild and the problem is mainly in the retina, so the patient really is unlikely to benefit from cataract surgery? What's the status of the retina? Because of what we discussed about the diabetic retinopathy, maybe at least possible progression. What's the status of the macula? And then is there any pathology requiring combined surgery? For example, the patient has vitreous hemorrhage, proliferative diabetic retinopathy, and vitreous hemorrhage. So he's unlikely to just benefit from cataract surgery. And also one important point is intravitreal injections, and especially how many injections he had. There's data that shows that multiple intravitreal injections, there's lens grazing, there's grazing against the capsule, which increases the risk of posterior capsule rupture during surgery at least by 2 times, especially if the patient had 10 injections or more. And the more we look in our patients who are receiving intravitreal injections, we see actually this lens grazes in many of them. And that happens during the time of intravitreal injections. So I think one important point really is, okay, this is the patient now, and just a scenario. This patient has diabetic macular edema and visually significant cataract. So what are we going to do for this patient? So what does the evidence show for diabetic macular edema in general? And then the next question, okay, now we have diabetic macular edema and cataract surgery. Are we going to change like our management because of the cataract surgery? So Dr. Dawood, you were talking about data from the DRCR network about a treatment of diabetic macular edema. Would you be kind to share your take on this data?
So yeah, this is a really important point. I mean, you know, we all know that poorly controlled diabetics or patients who do have previous macular edema, especially if it is involving the center, so we call it center involving macular edema, or even if they don't have currently center involved macular edema, but they have been treated for diabetic macular edema, they actually end up overall having a worsening outcome of, from cataract surgery than patients who do have what you said, non-proliferative diabetic retinopathy or diabetic retinopathy without macular edema. And what we see is that in the DRCR trial, for the patients who actually did have center involving diabetic macular edema, it's surprising to me that only 23% of the patients actually had preoperative and postoperative management of their diabetic macular edema, which usually is the treatment included lasers, including anti-VEGF, and included steroids. So when you look at it, about 42% of the cataract surgeons who were recruited by the DRCR network basically treated with anti-VEGF management. And when these patients actually are treated with anti-VEGF management, what you see is that their outcome is actually better. So when you look at the baseline, it's a small number because they really were having a hard time actually recruiting patients with center involving macular edema, meaning these patients have clinics delivering diabetic macular edema with thickening in the center. They did better. On the mean, it was 20/80 baseline, and then it was 20/50 afterwards. However, the patients did lose. Some patients, actually, about 30%, they showed no improvement, and even 10% showed worsening of 2 lines or more. And what they came out with is the fact that patients really need to have, number one, strict blood sugar control before the surgery. Number two, minimizing any involvement of the foveal with the diabetic macular edema, and really emphasizing pre-treatment, intraoperative treatment, and postoperative treatment to improve those. Because when you are only having proportion of patients, basically even after everything, 63% of the patients ended up having with eyes 20/40 or worse. That's not what we would expect with normal cataract surgery. So we really have to do a better job, a much better job, either as a cataract surgeon or somebody who is collaborating with the retina surgeon to really control the macular edema before proceeding with the cataract surgery.
Right. Thank you so much. Dr. Hussam, you wanted to discuss, as I remember from our previous discussion, the element of macular edema. Now I have a cataract patient with macular edema.
Yeah, it's a very crucial point. Yeah. Thank you, Dr. Ahmed. It's a very crucial point to know about this. The right way to deal with such cases. If I have a patient with a cataract and at the same time with a macular edema, how to judge the significance of cataract doing the cataract surgery? I'm still up till now, I cannot do cataract surgery before addressing the full treatment for the macular edema, except in just one case. If I don't have the pathway of the investigator, of any investigator to the retina, if I cannot get the OCT, clear OCT, also the cataract is so significant, is as significant as I mean that the patient cannot withstand his activities, his life activities, all his work. So I can go for cataract surgery with macular edema after treatment of the macular edema. Otherwise, if I don't have the time to address the macular edema treatment with the posterior segment surgeon first, I can go for cataract surgery, but with two very important points. The first one is I talked about the significance. The next I will talk about the intraoperative points I will consider. During surgery, I have to be careful about the fluctuation of the anterior chamber, about the vitreous loss. It will be very, very high risk factor to get a vitreous prolapse in such cases. Also, the fluctuation of the anterior chamber may lead to turbulence of the vitreous, which may increase the macular edema after the surgery. Let me say that I didn't see any patient with cataract surgery with previous mild macular edema without increase. It's worsening all the time. Yeah, I cannot say that there is a patient with cataract surgery with macular edema without any worsening for this edema, even all precautions. So I will ask you again, Dr. Sallam and Dr. Mahmoud Khaleel, as a vitreoretinal surgeon, there is there what's called the combined phaco injection or not in your practice?
So that's good. Maybe Dr. Khaleel, if you want to answer that first.
Okay. To me, at first, if I can do imaging, OCT thanks for OCT. OCT can image even in dense cataract, so I can at least categorize diabetic macular edema, whether it was fractional or it is not tractional, because the management is totally different. If the patient has tractional macular edema and significant traction, so I has to do phaco combined with vitrectomy. But if I have just diabetic macular edema, central involving, as Dr. Yassine said, or non-central involving diabetic macular edema, so I have a different approach. Fluorescein angiography is so important to categorize the stage of diabetic retinopathy. But if I can't image the retina because of the density of the cataract, so just I observe that the iris has no uses. I can look to the other eye. The other eye may give a guide to the state of the eye I will operate. So it is so important. But if the situation I has against cataract, I has a little bit non-center involving diabetic edema or no macular edema, for sure. At first, it was my thesis in master. Nearly every patient, every diabetic patient, post-operatively had some sort of increase in the macular thickness, even it wasn't visually significant. But mostly diabetics has a thickening in the macula post-operatively post-cataract extraction, even it was non-visually significant. So injection is an option to be done with phaco. And we have multiple options of injections. We have option of anti-VEGF injections, whatever the type. We have intravitreal triamcinolone, we have sublingual triamcinolone, and we have Ozurdex. And let us discuss with Dr. Sallam and Dr. Yassine what is the best approach for each one: anti-VEGF, intravitreal triamcinolone, sublingual triamcinolone, or intravitreal Ozurdex, or just non-steroidal anti-inflammatory topical medications.
Dr. Yassine, please.
As an anterior segment surgeon, usually I actually rely on the vitreoretinal surgeon to manage a lot of these. So I really defer to them on these questions.
Right.
But from the DRCR network, what we have seen is really whether it is laser or steroids or anti-VEGF, the anti-VEGF treatment, and sometimes it's a combination, as a matter of fact. If somebody does not respond to one, you may want to give them combinations, but the anti-VEGF seems to be over the long term holding the best in regard to visual acuity sustenance after 5 years and longer. But really, I would refer this to actually Dr. Sallam. He would know this. He would know the answer more than I do.
I'm not sure. So I'll tell you what I do. So I do really for cases with cataract and macular edema, the same thing. I would treat diabetic macular edema. So if it's non-center involving macular edema, then I would, and I feel like I can safely laser this, then I usually would do a focal laser. And it's very nice because it's usually, it wouldn't drop the patient vision. We do a gentle treatment to the area of thickening. And if it works, it's a one-off treatment. So that's what I do for non-center involving macular edema, which I feel that it will progress if it's free, like that it will progress and I can safely do this. If it's far away, I would not do anything for these patients. So we're talking only about diabetic macular edema. If it's center involving, then I use anti-VEGF for maybe 4 or 5 injections. If it's not working, I would switch anti-VEGF. And then if it's not working, I go for steroids treatment. And usually it's Ozurdex, and then if it works, the patient requires repeat injections, then I may use Illuvin. So that's what I do for just diabetic macular edema. So to apply this for cataract patients, I do the same. Usually laser is difficult because the view is not very good, but sometimes you can do laser if it's a non-center involving. Then I would treat them with anti-VEGF. My main aim is to stabilize the macula before cataract surgery, but as Dr. Hussam said, and Dr. Mahmoud mentioned as well, that sometimes it's difficult because the cataract is dense that you cannot really get a good OCT and you're not sure what's happening. For these patients, then I would use intraoperative injections, again, similar to what I do if there was no cataract. So I would use anti-VEGF, usually unless the patient was not responding to anti-VEGF. Then comes another group of patients, for example. So these are the patients with cataract and macular edema. But there are patients who don't have macular edema. So what type of prophylaxis we do for these patients? And maybe that would be a question to put back to the anterior segment surgeon. So you have now a cataract patient, diabetic, let's say mild retinopathy, and no macular edema. Would you do anything different, prophylaxis for them?
So the only thing that I actually do in that regard is the fact that what I do is I actually start them with the topical steroids and non-steroidals, usually a couple days before. So prednisone acetate 4 times a day, ketorolac 4 times a day, and I start them just 2 days before the surgery. That's what has been shown. And then I basically proceed with my cataract surgery without worrying too much about it. I, as a routine, if somebody has diabetes and I see NPDR, I would get a baseline OCT before the cataract surgery, just so that at least we have, we show the patient, we advise the patient, we basically say, this may affect your vision regardless. But in regard to the management itself, I basically just start those 2 steroidals and non-steroidals. As Dr. Ziada said, once you proceed to the surgery, the minimal manipulation, less inflammation, gentle technique really lessens the risk of macular edema in these patients' populations. The DRCR network, basically, if somebody does not have macular edema preoperatively and they have not been treated for macular edema preoperatively, they tend to actually do pretty well. So, basically, 17 of the 17 patients who did not have a history of macular edema, of course, the sample size is 60, so it's very small, actually ended up not developing, significant macular edema after the cataract surgery. Now, I agree that on the OCT, there was thickening, but it did not translate to visual acuity. So therefore, I don't do anything except of the preoperative topical management.
Okay, can I add something?
Yes, please, yes.
Okay. Thank you. Thank you very much. You are, all of us are the bosses today. Dr. Yassine, I want to go back for the anterior segment surgeons, how to keep the anterior chamber stable during surgery. First, by adjusting the flow rate, the body height, and actually the listening to lessen the times of or the frequency of entering and exiting of bifocal probe. And about the side ports too. It will keep the anterior chamber stable, especially when I shift from one step to the next one. I have to keep the anterior chamber stable, even by injecting viscoelastic to avoid collapse and loss of the anterior chamber during some steps. Actually, really, according to my short experience in this field, but actually, I found good results with them. When I keep these rules and helping points during surgery, I have found a difference between the different patients or the previous patients, which I have done before, considering these points, and the other patients I have done after. I found that the frequency of worsening of the macular macular edema is much less, especially if I give them non-topical, the non-steroidal eye drops before the surgery, 1 week before surgery, and then complete it for 1 month after surgery, together with a steroid and antibiotic. Really, it's very, very important, crucial to consider to keep it to deal with, like the high myopic patient. You are scared from the fluctuation with traction of the vitreous to do any retinal tears in the periphery. The same here in the diabetics. You have to keep the anterior chamber stable all the time, and also to decrease the risk of the vitreous prolapse. The second point, when I found that the central non-center involving macular edema, supposing that the visual defect is related to the cataract density, so I have to measure, I have to correlate the cataract density significance to the visual defect. I think we can read that, we can know that if the amount of visual defect is related to the cataract density or to another pathology in the retina. Another point I want to mention is the HbA1c, to know about the control of the diabetes. I may have the patient with very low fasting and postprandial in the week before surgery, but about the history is not well. So I think the gut control for a long time and enough time will help me to get a good results after that and to avoid the macular edema postoperatively, like the Irving gas syndrome. Let's agree that the phacoemulsification procedure, even uneven fall, will affect the macular thickness, even in the normal patients, not only the diabetics. I think you agree with me to this point, right?
So I think now we're moving to the intraoperative management of the cataract patient with a history of some diabetes, and I totally agree with you. I think the preoperative management for you with the non-steroidals is very reasonable. These patients, you have to realize that diabetes, they do have diabetic keratopathy, so their epithelium can actually peel off pretty easily. So you really have to be careful with that. The iris can actually also be a little bit long-term ischemic. Sometimes you really have to look for, of course, by that time that you have corneal, iris neovascularization from the diabetes, that the patient has been very poorly controlled. But the iris is going to be a little bit atrophic. It may be a little bit of a floppy, so you have to be able to manage it. I tend to actually operate a little bit more up into the AC, therefore not as much ultrasound energy is actually delivered to the posterior pole, and therefore it may decrease the risk of macular edema, although there's really no clear evidence to that, but at least theoretically it makes sense. So those are the major things. And so less manipulation, less fluidics, making sure that you don't, in these patients, they also have zonular weaknesses from the diabetes. So you really have to treat them as relatively high risk. If a patient does not have diabetic retinopathy, very likely they'll do just the same as well as your average patient. But if they do have a good amount of diabetic retinopathy, you do have to start thinking about what else is going on. We do have at Wilmer a weird machine that really, but it's very effective, which is the PAM potential acuity meter. We do have actually the real potential acuity meter. You could actually do pinhole PAM for these patients to see what is their vision potential as well. That can give you a little bit of an idea how much of the cataract, how much of the macula, if it is playing an issue. But many times I agree with my esteemed co-speakers that if the cataract is bad enough, you may not have a great appreciation how the macula is doing. And in that case, I also counsel the patient that, look, your vision may not be 20/20 or whatever it is, because we can't see the macula as well as we would like to, but we will have a better understanding of it afterwards.
Okay, Dr. Yassine, thank you. But you may feel that I am stuck to this point because I have seen a lot of patients who were undergone phacoemulsification in non-significant cataract, and they were diabetics with uncontrolled diabetes, and at the same time with very early macular edema. And from 2 years ago, I'm following these patients with a macular edema, which is persistent macular edema, in spite of a huge number or many injections, intravitreally and subtenon or periocularly. This is the issue which I want to ask again to all of my dear guest speakers about. There is what's called phaco injection. If you have a macular edema, to inject pre-operatively, pre-phaco, or intra-operatively with the same session with phaco. This is the question here. I don't have the urgency to do the phacoemulsification in the case of macular edema. I can inject many times until having a good macula, or dry macula, and then go for the cataract. The only case which I can go for injection, then follow it immediately with phaco or combined together phaco injection, I think it will be the significant cataract, which is stopping the life activities of this person. So, and Dr. Mahmoud-Khaleel knows about this. It could be a matter of malpractice in ophthalmology now. In the diabetic patients with a macular edema and with medium, moderately significant cataract, I think many surgeons may go for a combined phaco injection. So it is evidence-based. There is a scientific base for that, or it's an individual opinion or practice. This is a question which I want to clarify it, please.
So if I may answer this, so there are several good retrospective papers really that showed good response in diabetics and uveitic macular edema using combined intravitreal injections and cataract, mainly using Ozurdex, which I think really is reasonable. But the main thing really, this is not a one-off treatment like diabetic macular edema or even uveitic macular edema. It's not a one-off treatment. So I don't see the rationale of just injecting at the time of surgery. And I think it seems like we're all agreeing that if you have macular edema before at the time of preoperative pre-assessment, then it's best to stabilize the macula, then go for phaco. If the cataract is dense, that you cannot really monitor the macula well, then maybe an injection before the surgery, like 2 weeks before the surgery, or at the time of the surgery is sensible. But afterwards, the patient needs to have like needs to continue with the management. And I think the message I think is stabilize the macula first and go for cataract surgery, unless if the cataract is dense, it's fine. You can do that at the time of surgery, but afterwards, the post-operative management is very important. It's not a one-off treatment.
Yeah, okay, thank you very much. I think it's clear now. But the last question before going to the next point is the blood sugar control. If you have a glycosylated hemoglobin of 10% or more or less, but it's away from the normal figure. But you have today or the day of the surgery, you have a good random blood sugar or within normal random blood sugar. Would you go for the surgery or to control it first? You may depend on the random blood sugar on the day of the surgery as well. So you may feel that you are away from the increased opportunity for the infection, but actually about the vascular elements of the retina, about the possibility of disruption of the macular blood capillaries and getting edema. Will you depend on the HbA1c, which is the glycosylated hemoglobin, denoting the period of control, or the random blood sugar on the day of surgery? Tell me about your practice and your experience in that, please. Okay, starting with Dr. Khaleel this time, please.
Okay, gotcha. So it is so important to do a very meticulous patient counseling pre-operatively. Diabetic retinopathy is a long-term disease. We are not attacking a single pathology and finishing the situation at the end of the operation, but we are going with our patients for a long time. So the patient must be counseled that the problem will not be finished with cataract extraction, will not be finished with cataract plus injection, but we have long-term management. Yes. We have long-term. We may need further injections. We may need laser treatment. Before all of this, we have to make a good control of blood sugar. The short-term control is important for doing surgery, but the long-term control is important for the eye of the patient, for the vision of the patient. So in one of the studies, lowering the hemoglobin A1c by 1% will lessen the diabetic retinopathy progression by 30%. So it is so important. So important, yes. Yeah. To have a long-term control.
Dr. Mahmoud, hence I'm talking about the dry macula. I'm talking about a patient with dry macular, even with macular edema, but non-center involving, but with uncontrolled blood sugar. So please complete your answer on this base. Yeah.
Yes. So short-term control is important for surgery to get rid of infections intra or post-operatively, and the long-term control is guaranteed by controlling the hemoglobin A1c, controlling the blood pressure, controlling the lipid profile of the patient, all of the three of the metabolic syndrome, controlling all of the three parts will make some guarantee to the patient for keeping him away from further complications, further proliferations, and doing further surgeries. So the message is to do making a patient counseling good, making a good systemic control involving the 3 points: blood sugar, blood pressure, and lipid profile, and then going for surgery.
Okay, perfect. Thank you very much. Dr. Salam, you have any comment?
Yes, I have a comment on this three, which might be slightly not mainstream.
Yeah.
So I totally agree with Mahmoud that long-term control is better for diabetic retinopathy. That was shown really in several studies, right? The UK PDS study, which looked at type 2, and also the diabetic complication. So what's it called? The
ECS.
Yes. What is it called again? I'm sorry, I've missed it. I don't know why.
Is it a diabetic complication study?
Yes, I think it was diabetes control and complications, I think, and that looked at type 1, and they showed really that tighter control definitely improves retinopathy and neuropathy and kidney disease. So that's really like, out of discussion. The main point really is, okay, well, you have this patient with high blood glucose and poor controlled hemoglobin A1C, and the patient now requires cataract surgery. Are you going to postpone the surgery till his hemoglobin gets better, A1C? That's really, we're talking about maybe 6 months, a year. And we're dealing with patients really who were advised before several times that they need to control their diabetes, but they do not. Because of their lifestyle, because of, their frustration. So I think we have to be realistic here. Then the other point really, okay, if we operate on these patients, are they at risk of developing problems from surgery, mainly endophthalmitis, or not? And in many cases, we have these patients in our list. We come to the operating room, and then we find that the anesthesiologists say, we have to cancel this patient, right? Because their blood sugar is 400 or 450 or 300. The way I do it is I tell them, as long as the patient is hemodynamically stable and is not in diabetic ketoacidosis, we would like to operate on these patients, because there's no evidence whatsoever shows that short-term control changes the outcome of cataract surgery. And there's a very beautiful paper I was trying to find by UK and US group that showed this and went through all the evidence. And in my view as well, it's best to have these patients have their cataract surgery so that they can see better and look after themselves better. And maybe really their hemoglobin A1C will get better if in the future. So I think long-term, yes, totally agree. Short-term, I think really there's no reason for canceling those patients, and I would not really look at a number. And when anesthesia asks me, what's your number? I say, what's the blood glucose? They say 328. I say, okay, my cutoff is 329. That's what I do.
Okay.
And I'll find a paper. It is a very nice review article.
Okay, please, when you find it, please send it to me. And
so it would be interesting to hear what Yassine would say on this, especially that he's a cataract surgeon.
So one of the leisure points that I have is, I'm a high volume surgeon. So, but I also have a backlog of about 2 to 3 months. So I can't operate on the patient for 2 to 3 months anyway, typically, unless it's urgent. So basically, I'll give you the example of a 24-year-old that I literally saw yesterday who has diabetes, and she has NPDR already. And I asked her, she's not on a pump, she's not on anything, because really lifestyle, it hasn't really impacted her. So I sat her down, and she has beautiful cataract. And, she's, I think, 2200 in one eye and 2080 in the other eye from the cataract, not from the, she doesn't have macular edema per se. And I sat her down and I said, would you like to be blind in the next 10 years? Or sort of thing. I wanted to kind of put the fear of God in her. And the fact that she has to drive to go to work and this and that. And I said, look, I'll try to do your surgery sooner, Logistically, for me, it's not actually the A1C. It's more like my schedule really is not allowing me to do the surgery. But I do use that time frame to convince the patients that, look, you need to control your diabetes. And I agree that, you know, we are ophthalmologists, many times we become very super focused on the eye, but in the end, we really have to take the patient all as a whole. And with that patient, she left the clinic kind of be fearful that her, you know, her blood sugar was, well, her A1C was 13. So, I mean, that was ridiculous. And I was like, okay, you need to really control your blood sugar. And I would like to see your blood sugar being somewhere around below 10 by the time I do your cataract surgery. Is that because it's going to make her outcome any worse? I don't think so. In the short term, it's not going to make much worse. But if I can get her on a path to controlling her blood sugar, that is part of the medical treatment that I have for this patient. But I very much agree with you. If a patient does not have significant diabetic retinopathy, short-term control of their A1C is not going to make a whole lot of a difference.
Okay, Dr. Yassine, I agree with you, but we can see it in a different way. That when we have a patient with a significant opacity, we can do. But if there's a patient, I can wait and I can prepare. I think it's much better to control the blood sugar first. I'm not talking just about the post-operative infection, the endophthalmitis, or these points, but I'm talking about the macula, the retina. I think that the blood sugar control for a long time will keep the vasculature of the retinal vasculature more stable. I think we have a lot of problems post-operatively with the diabetic patients after cataract because of the breakdown of the blood barriers everywhere in the anterior segment or the posterior segment too, right? So the control will help us to decrease the incidence and decrease the opportunities of the different complications post-operatively. But actually, I got a patient before Eid.
You get to talk about that review.
Yeah, no, I was just gonna say, I think it's, yeah, you totally agree. Like, you have diabetic patients in the clinic getting injections, anti-VEGF, right? So would you say, like, let's hold off on the anti-VEGF until you control your hemoglobin A1C? The problem is, yes, they should control it, and we know, but the problem is, the reality is, like, more than 50% of them, much more, will not control it. Yeah. So I think it's, you know, yes, we definitely advise them, and I advise them, and I'm not saying really like, no, I'm telling them, we don't care about that. No, definitely it's important. But I just I feel like I'm a bit slightly against canceling cataract surgery, for example, on the day because their blood sugar is high, because really the evidence is not there. That's the point. But I think we're all on the same page.
Yeah. I think we have the same patients everywhere who will say to us, just to tell them about the control. Doctor, I tried many times to control the blood sugar, but it's not controlling. It's not controlled. What can I do? Even the internist.
It's like patients who are smoking, right? So, yeah, you know, you tell them not to smoke, yeah, but they're smoking. I mean, what are we going to do?
Yeah, we have to deal.
We're only the advocate. They decide. We're just the advocates.
We have to deal it with as such. Yeah, okay. But actually, I have two different patients with the different ways. We was enthusiastic to inject all patients with the macular edema when we were starting to know about, but I was admitted with a vitreoretinal surgeon 8 years ago, and he was a very good and experienced consultant about that. I referred a case with the macular edema, with center involving macular edema, and I was sure that he will inject this patient, but diversely he sent the patient for the medical treatment for 3 months, and then we set the patient again with a newer OCT with an improvement with just the medical treatment and some exercise. So today we are thinking in different way. We can do an alternative therapies away from the injection before going intraocularly by the injection. This is the point which I want to clarify about the diabetic patients with the cataract surgery. To do with the patient, with every patient individually, according to the case, according to the blood sugar control, according to the significance of the cataract density, and so. But we are all agreeing now that there's no what's called phaco injection in all cases of diabetics, right? It's not a prophylactic treatment to inject during cataract surgery for the diabetics, right? Dr. Yassine, okay?
I'm not aware, actually, that's a practice in the United States. We don't do phaco inject. I mean, the only time we would do is if there is diabetic macular edema. And I normally, usually we inject in the outpatient setting. I send them to the retina surgeon the week before, 2 weeks before, depending on the cycle, when I'm doing the cataract surgery, and that's it. But if somebody does not have, existing macular edema, there is really no data, to the best of my knowledge, as an anterior segment surgeon, that phaco inject makes a difference in the outcome of your cataract surgery, or that it lessens the risk of your macular edema. If somebody has that data, I would love to have a look at it. But my understanding is, at least in our institution, none of us does it. Okay,
thank you, sir. Dr. Sallam?
Yeah, no, I think same here. So if they have no macular edema, then I would do something like, I would always do something. So I would give them usually topical non-steroidals, which we start after the surgery. We use Macular. Sometimes we use Nepafenac, and we started just before the surgery, but we use now Macular, Cataract. If they have macular edema, then what I discussed, we try to stabilize the macula beforehand. If not, then we may go for phaco injection. But the main thing is the treatment needs to continue afterward. I just want to share with you a slide from a paper we did in 2015. I just found it as we spoke. Really, it's a big data. It's a 40,000 diabetic eye out of 80,000 patients who had cataract surgery. So this is a retrospective study, so that needs to be considered, but it's really big data from 8 centers, from 8 UK centers. And if you look down here, if you have no diabetes, your risk of uneventful cataract surgery is 1% having macular edema after cataract surgery. So these are excluding patients who had diabetic macular edema before or any macular edema before. So you risk about 1%, which we know. If you have diabetes and no diabetic retinopathy, your risk becomes 2%. If you have mild, moderate, and severe, your risk goes up from 3 to 7%. And if you have proliferative diabetic retinopathy, your risk goes up to 10%. So I think that supports really like some sort of prophylaxis before the surgery for patients who have diabetes even without retinopathy, and let alone patients with retinopathy. And that's the paper I was trying to allude to about the glycemic control before the surgery and the blood sugar level. It's a very nice review article, really very nice.
Yeah. Okay. Arnan the Wiser. Okay, Dr.
Yes.
Dr. Sallam, Dr. Mahmoud-Khaleel, what's your opinion about the periocular or subtenonian injection of steroid, of triamcinolone, instead of the intravitreal injection?
Okay. At first, Dr. Hassam, I know you are stressing on the effect which is happening in our country, that diabetic patient, when he is going for cataract extraction, he always go for phaco anti-injection. It is the concept in the mind of some
surgeons. Yeah, you know that we are caring about the social practice in the medicine. Yeah.
Yes. Yes.
Yeah, okay.
So it is worse enough to say that even in the worst conditions, macular edema or diabetic retinopathy can go back even with just systemic control. It is not so common, but it can happen. So the message is don't rush into phaco injection in every case, even in patients which doesn't have any diabetic retinopathy or macular, or even macular edema. So it is the point. Preoperatively, non-steroidal anti-inflammatory topical medications go well regarding decrease in the prostaglandins, which included in the pathology of diabetic macular edema. Also, it makes the pupil, it makes maintaining the pupillary dilatation intraoperatively. Especially, we need to do a relatively large capsule, anterior capsulorhexis, because this patient may come back and we are need to do retinal photocoagulation PRP, and we have some difficulty in having peripheral capsular opacification, or even the patient may need posterior segment surgery, and this make a difficulty in going. So we non-steroidal anti-inflammatory drugs make a good function in maintaining also maintaining pupillary dilatation intraoperatively to go for more large capsulorhexis. Regarding the subtenon triamcinolone, I made it several times, and it makes a good function. Regarding it, maintaining at least the macular thickness at its preoperative point, or making some improvements. The improvement is not standing for a long time, but we have the advantage of lessening the risk of intraocular injections and lessening the risk of IOB increase, which can happen with intravitreal steroids. Yes. So subtenon triamcinolone can make a good function. It can stay in the eye nearly 2 weeks, make a good function, making the early perioperative increase in macular thickness is less. So I did it several times, and it makes a good function.
Yeah, okay, very well.
Right. So, I mean, I think the last thing really here, I don't know if you want to have some discussion on like operative considerations in diabetic patients having cataract surgery. So the pupil might be an issue. Dr. Yassine said their pupil may not dilate well. Capsulorhexis are any considerations, and then we talked about irrigation aspiration and AC stability. And then we talked, I think, about periocular and intravitreal injection. In my practice, I think periocular might be an alternative for ocular. There's mixed evidence in the literature whether subtenon Kenalog really helps the macula. But I think it's probably like ocular in patients who do not have existing macular edema. One thing which I do sometimes is sometimes when patients have proliferative retinopathy and the view is very bad, then that's really when I do a phaco injection. That's a good point of like maybe a phaco injection, where I would do for these patients, I would do the cataract surgery, I would give them an intravitreal anti-VEGF at the time of the surgery. And then I would put a suture and come later on 1 or 2 weeks after the cataract surgery and do PRP for patients who have proliferative retinopathy and very dense cataract. If I cannot really laser them well before the surgery. Sometimes I would laser them with the indirect ophthalmoscope before removing the viscoelastic. That's not an option that many people can do because of the setup. That sometimes I do as well. So I would do in that scenario, cataract, intravitreal injection, cataract, then I put the indirect ophthalmoscope, laser them, and before removing the viscoelastic, I would put an intravitreal anti-VEGF.
Yeah, okay.
I don't know if you want to discuss like pupil management, or we can discuss that with the uveitis and what, for example, Dr. Yassine as the cataract surgeon would do for the pupil management, whatever you would like.
So basically, I mean, we'll come to that actually in the uveitis because I have a couple of videos, one of them with the hooks. So we'll come to that regarding if the pupil is misbehaving and whatnot. The capsulorhexis, I agree that having a little bit larger capsulorhexis may be helpful, especially if if the zonules are a little bit on the weaker side. Having a larger capsulorhexis will enable you to either prolapse the lens and operate mainly on the iris plane or in the anterior chamber, so you're not putting a lot of stress on the zonules themselves. And it will improve or make the life of the vitreoretinal surgeon a little bit easier if they want to go with the peripheral PRP. So those things I think are very important. But the iris invariably in the diabetic patient behaves differently, especially if they've already started having any sort of diabetic retinopathy, you know that there, and a very quick way to do is that what is the preoperative dilation of the pupil? If the patient dilates well, you pretty much can assume that it is going to behave well. However, I have been surprised many times that, you know, I don't put anything in my surgical note about the pupil, assuming that it is good in the clinic, and then you come to the OR, and the moment you start opening up, the iris starts, you know, misbehaving and going haywire. So you always, for me, whenever I see a diabetic patient, long-term diabetic patient with early signs of diabetic retinopathy, I am ready for, you know, pupil management issues at the time of the surgery. So it's always better be over ready rather than be, you know, unprepared. The IOL, that's an interesting question, and I'm actually, what do you guys do in regard to the IOL choices? What do you use?
I use a hydrophobic IOL for diabetics and for uveitis, and in general, really, one-piece hydrophobic lens.
Both of them,
ahead.
yeah, both of them. Okay, I use the hydrophobic and the hydrophilic together, with no significant difference between both of them. Okay.
I generally use a 3-piece IOL in diabetics, especially if they are advanced diabetics, just because, you know, sometimes if they have zonular issues and whatnot, I can easily, it gives them a little bit more support. Usually especially if I'm doing actually surgery with the retina surgeon, I always pretty much almost invariably use a 3-piece IOL. I find that it holds itself better as the retina surgeon is operating. But if I'm only doing the surgery by myself, really a hydrophobic IOL works very well. I try to avoid silicone-based lenses in these patients, because just in case, if they do have a potential for retinal detachment in the future and whatnot, and silicone oil, so you're calling for a little bit complications and whatnot. So that's the only thing that I do, is I try to avoid silicone lenses in these patients.
But actually, I think, in my opinion, the most important one, the larger capsulexes and the wide diameter IOL, for the good exposure and to avoid the capsular phimosis and the fibrosis of the bag, and not for the vitreoretinal surgeon to hit us during the posterior procedures.
Sam?
Yes.
To me, I use single piece hydrophobic IOL. My question is, does it make a difference to do hydrophilic or hydrophobic in such case in diabetic retinopathy? Does it make a difference in your hands, Dr. Ahmed, Dr. Yassine, Dr. Sam?
I haven't used too many hydrophilic, but I think they have the reputation that there's more inflammation. So we tend to use really more hydrophobic lens.
In general,
My worry with hydrophilic lenses is that if you're doing retina surgery in the future, which really like a good number of patients would have, even without using oil, and you just use air or gas, if the posterior capsule is open, then the lens would fog. And that can make a problem with visualization during the surgery. And that's actually the main reason to avoid silicone lenses during in diabetics. It's because of using silicone oil, but even like the fogging is much more with silicone lenses compared to acrylic hydrophobic during the surgery, during air fluid exchange. So I try to avoid them when we use mainly hydrophobic.
Okay, Dr. Salam. About me, before going to Dr. Yassine, I have implanted both types, hydrophobic and hydrophilic, in each eye of one patient, one hydrophobic and one hydrophilic in diabetic patient, and I tried this in 3 patients to know the difference, or to check for the same patient, but actually there's no difference between both of them.
Right.
Yeah, okay. Dr. Yassine.
I mean, you know, for an N of 3, it's really hard to determine, but really hydrophobic and hydrophilic, the current design of the lenses, both of them are very acceptable in these patients. I think the market in the United States is mostly just because of companies that give these lenses. We mostly have hydrophobic lenses. I tend to have the, the MA50BM. I don't have any financial interest in it, but it's about 6.5 millimeters 6 millimeters optic, 6.5 millimeters optic, and 13 millimeters diameter. So it really tends to occupy a good amount of space in these patients. And in case they do have any other issues, you can easily suture it to the iris in the future in case there's dislocation or decentration and whatnot. So that tend to be my favorite lens for these patients. But is there any evidence to answer your question about hydrophobic versus hydrophilic? No, there's really no long-term data to show one that is significantly superior to the other in this patient population.
Okay, thank you very much. What's the next point, Dr. Salem?
I think that's it. And I mean,
we have finished. We have covered all the points.
I think this is I think, you know, like my just small message is like, it's not a one-off treatment in diabetic patients having cataract surgery.
Yeah.
And we need to control the treatment, the retinopathy and the maculopathy. Sometimes as well, what I do is in high risk, in severe NPDR, I even may consider them for PRP after the cataract surgery. I just worry about these patients going, especially if the follow-up is not very good, going and not coming back. So I think it's yes. So I totally agree with you. It's not a one-off thing. It's not just a fake on an injection. It's more of a long-term treatment.
Yeah. Okay. So I will catch the opportunity of your presence, Dr. Sallam and Dr. Mahmoud-Khaleel, as a veterinary surgeons, and ask you about the persistent macular edema despite of 25 times of injections of all different names of the anti-VEGFs. Can I think, or I will refer to the posterior segment surgeon, but it's wise to think in the vitrectomy in such cases. The OCT doesn't show any epiretinal membranes or any thickened membranes or thickened ILM for this patient, but still persistent cystic changes in the macula, in the fovea, to consider the vitrectomy or to inject again.
So Dr. Khaleel, if you want to start.
Okay. First of all, Dr. Hassan, we will come back. The most important thing is to do a systemic control. If you are not doing systemic control, it is like opening the tap and you are drying the floor, and
yes.
Still you are opening the tap. So it's still accumulating fluid all over the time. So first of all is to do a meticulous systemic control. Second thing, resistant macular edema. After 6 injections of the same anti-VEGF, which is the mainstay for treatment, you have the first to switch to other anti-VEGF. It may make a difference. So if you are using one anti-VEGF, you can shift to the other and go for the repeat dose again and see what is happening in the macula.
Mahmoud, okay. Do you believe in accumulative effect of the anti-VEGF injections? Yes.
Some patients are late responders. Doesn't respond in the first injection, but it can respond later, and this happens really in our life. Second thing is to think in intravitreal steroid or steroid implants like Ozurdex or Olivine. Third thing is the last stay we can do is to go for vitrectomy if we are not responding to all of this medical treatment, to all of this pharmacological treatment.
Vitrectomy with ILM peeling should be or not?
Non-fractional diabetic refractory diabetic macular edema. Till now, no review in the literature review. No, it doesn't make a difference to make ILM peeling or not.
Wouldn't think in the thought ILM in such case?
Okay, it may, but it will be evident on OST. But
I know that
just
yeah. Okay. Go ahead.
Just vitrectomy, it makes a low load of VEGF in the vitreous vehicle. Meticulous laser in the peripheral ischemia, it can make a difference even without ILM peeling.
Okay.
So I'll check the opinion of Dr. Salem.
Before We're going, Dr. Salam, let me say that the two, I have three cases of persistent cystoid macular edema, despite of the different type or many times of injections. All of them are post-phaco care, post-phaco emulsification. Unfortunately, all three are post-phaco. So I'm today insisting to talk a lot about this point. So please go ahead in your comment.
So yeah, I think it's again good point. So I think one important point really to consider is this a diabetic macular edema or this is a pseudophakic macular edema. Sometimes the differentiation is difficult, sometimes it's not, and there are like different ways to help differentiate between the two. Let's talk about diabetic macular edema. I would do exactly like what Mahmoud says, really. So I would do anti-VEGF, switch to another anti-VEGF, and yes, the DRCR showed that there are patients who are late responders and responded after the 6th injection. Then I will go to steroid. Then the question is, if there's no traction, would I do vitrectomy? Usually no, I would not do vitrectomy. I may have done this in the odd patient, but in my experience, they don't really do well. And there's really very, very mixed literature about vitrectomy in these patients. If there is traction, yes, I will do vitrectomy earlier on these patients, especially if they're not responding to medical treatment.
Okay, can you differentiate between the pseudophakic and diabetic macular edema and diabetic patient?
Yes, no, I agree. So really the most important parameter is to have access to the patient's note beforehand and to see whether or not they had macular edema before surgery. This is the single most important metric. Is if they had macular edema before the cataract surgery, then it's really, this is a diabetic macular edema that just got worse after cataract surgery. And I would treat these patients as diabetic. Then there are other things, really, the appearance of the macula itself. For example, if they have exudates and hemorrhages, then this is more likely diabetic, right? Then the other point is how they leak on fluorescein in the absence of NVDs. So Irving gas is an inflammatory condition of the posterior pole. So if you do a fluorescein, they would be also leaking from the disc. Diabetics would not do this unless they have NVDs. But really, it used to be like the main parameter was the fluorescein leakage, but there was a very nice study from Mufas that showed actually that the main parameter is whether they had macular thickening before the cataract surgery or not. I'm sure there's stuff on the OCTA to differentiate. I'm not really aware. I haven't looked into what parameters on OCTA would differentiate, but that's what I go with.
Okay, perfect. I think
I'm going to add one more question to the panel, actually, since we have the vitreoretinal surgeons as well.
Yeah.
There are patients who have macular edema before cataract surgery. You know that it is diabetic macular edema. You have given them 5 and 6 injections, and you've delayed their cataract surgery because they still have active macular edema, and their vision is not great, and they do have visually significant cataract. When do you operate? They still have persistent macular edema. Do you operate, or do you say, no, I'm going to make you worse?
Dr. Salam, Dr. Mahmoud.
I would operate. I mean, I would operate. Maybe something really I may do differently is I may give them an intravitreal Ozurdex at the time of surgery. For example, if they're having anti-VEGF and they are showing like some response, but not like, they are not like a total responders, I may actually give them an Ozurdex at the time of surgery. But I would operate if the cataract is dense and their macula stabilized as much as I can before the surgery and the patients are getting frustrated, I will get the cataract out of the way. And I probably will do something different. Either I would operate like within 2 weeks from an injection, or I would give them an intravitreal Ozurdex at the time of surgery.
Yes, yes. Thank you for your great answer. This is a question. I think it's my question my first question at the beginning of this meeting. We have to jump to the next topic because we talk more than 1 hour in this point. So we'll go to a different category of point, going to the surgery. with cataract surgery with intraocular foreign body with Dr. Mahmoud Khaleel. Please, Dr. Khaleel, share your screen.
Now shown on the screen?
Yeah, it's clear now.
Okay. Okay, we have just a small introduction. Always we have a resident call, I have rupture globe. Any opening in the globe is a rupture globe. But actually this is not true. So we have the basic classification, Birmingham Eye Trauma Terminology Classification, which has classified the eye injury into two main categories: closed globe injuries and open globe injuries. Closed globe injuries when we have intact a globe ball. Globe ball is the sclera and the cornea. Open globe injuries when we have a full thickness bond inside the sclera or inside the cornea. After we categorizing the closed globe injuries and open globe injuries, closed globe injuries are furtherly classified into contusion and lamellar restoration. Lamellar restoration is a partial thickness wound inside the eye wall. Contusion is direct injury like suprachoroidal injury or from sharp trauma or blunt trauma causing like angle recession glaucoma. Open globe injuries are further classified into two main categories: rupture globe injury and complete sorry. Rupture globe it means that the patient has a blunt trauma and sudden expansion of the globe, which will lead to opening of the globe at the weakest points. Weakest points is like the insertion of the recti, or like previous cataract surgery or previous squint surgery. So it is only called rupture globe. Rupture globe meaning blunt trauma leading to a complete full thickness wound inside the globe. While the penetrating injuries is further categorized into 3 points: perforating injury, interocular foreign body, and penetrating injury. Penetrating injury meaning that the injury has a single entry site. Perforating injury has an entry and an exit. And the interocular foreign body meaning that the foreign body is settled inside the globe. First assessment is first to do no harm, exclude life-threatening conditions, assess both eyes, assess measure 4, assess type of injury, assess extent of injury in clock hours, assess visual acuity, and assess the pupil reactions. It is important not to jump into anatomical repair and forget that the patient may have a traumatic optic neuropathy, which make the vision is compromised and the further improvement in vision is little and may lead to optic atrophy. Second thing, it is our talk, interocular foreign bonds are categorized into toxic foreign bonds and inert foreign bonds. Toxic foreign bonds, metallic foreign bonds like iron, steel, nickel, and copper, non-metallic like vegetable matter. Inert foreign bonds like gold, silver, platinum, it doesn't make an injury to the globe by chemical reaction, and non-metallic like glass and carbon. Foreign bonds can make injury to the eye first with mechanical trauma, hitting the cornea, hitting the sclera, making a wound, hitting the iris, making iridosis, hitting the lens, making cataract, or making subluxations. It can also make inflammatory response. It can make a chemical reaction like cirrhosis and chalcosis. Organic foreign bonds can cause endophthalmitis. It is the rule not to do MRI, to not any movement inside the eye. First case, as we see, we have an entry and we have an opening in the anterior capsule and we have an opening in the posterior capsule. So the first thing to put in our mind in foreign bodies can make trauma to the anterior capsule, can make an opening in the posterior capsule. So we have to put this in our mind. Also, it can make a trauma in the nose and making lens subluxations. Even if it's apparently not subluxated, but it will appear with time while we are operating inside the eye. After we are doing capsulolysis in this patient with young patients, so we can go just for fecal emulsification, and we don't need to do lensectomy. We have to go meticulously because the posterior capsule is opened, not to lose a matter dropping fragments inside the vitreous cavity. When we are extracting the foreign body, we have two pathways. Either we extract it from the EC, from the anterior chamber, or we extract it through the sclera. It is my preference to extract it from the anterior segment, so I postpone the IOL implantation till the end, using the posterior capsule rupture as an exit for the foreign body, and it makes the life easier. It makes we doesn't need to make non-stability of the hemodynamics inside the eye. We doesn't need to make a large scleral tunnel. So I postpone the IOL implantation until complete removal of the foreign body. As a rule, we don't jump inside the removal of the foreign body, but we have to remove vitreous meticulously. Even we have to do a complete posterior vitreous detachment to make the foreign body floating inside the eye freely without making an injury while tracting the foreign body and grasping. In this case, I remove it with the help of the float needle, passive suction, delivering it inside the EC, and with the help of post forceps, I will catch the foreign body and remove it. Using first a forceps from the side wound, and then delivering it outside the eye. We use two forceps because the fluid needle is a passive aspirator. So if the IOP is fluctuating, it will fall back inside the eye. Then at this point, we have to decide what will implant. If we have just posterior capsule bridge, the sinews are intact, we have enough frame, you can go with 3-piece IOL. But if the conditions are not stable, we have to think in other things, as we will see. In this case, we are implanting 3-piece IOL, and then check for the retinal periphery to be sure that there is no breaks, there is no injuries in the periphery of the eye. In this case, we have just small breaks, small toe breaks in the peripheral part, and making a barrage. Second case. Second case with a large foreign body. As we see, sorry. As you see, this is the intersite. It is a valvular wound. By the way, this patient had did LASIK before, and he has a flap of LASIK. This is the intersite. When we see this posterior capsule opacification, this means that mostly the posterior capsule is open. So we have to be cautious while doing anterior segment surgery. In this case, we have vitreous prolapsed intraoperatively because through the open posterior capsule. So we have to do anterior vitrectomy to make finishing the removing of the cortical matter. And also, as we did before, we will postpone the implanting of the IOL until complete removal and the complete dealing with the posterior segment pathologies. Removing the vitreous hemorrhage and suturing the one. This one, by the way, was sealed, and the intraoperative, while the IOP is elevated, it opened, and this, so I need to make a suturing in this valvular wound. This is a foreign body entangled with the vitreous hemorrhage. Removing the vitreous hemorrhage and freeing the foreign body from all around, and then catching the foreign body using the basket forceps, and also delivering it to the anterior chamber, using the iris as a scaffold to keep the foreign body until removing it from the mean wound, from the mean corneal wound. And then the rotation to make the removal is more easier, removing it using the McPherson from the EC. In this case, I implanted the PMM because I dilated the wound more than needed. So I implanted the single piece PMMA IOL as the posterior capsule rent was through capsule remnant was so good to keep the IOL in place. And then finishing is the case. So special considerations, high incidence of posterior capsule rupture. We have to make this in our mind, either in blunt trauma or even in penetrating trauma or with intraocular foreign body. We have to be ready with all types of IOL. So if we have a good capsular rim, we can plant 3-piece IOL or BMA IOL. If we don't have enough capsular rim, we may use the iris glow lens, which to me I prefer it, or to use the scleral fixation IOL, either with the classic technique or with the recent techniques like many techniques. So be ready with everything. Completely ready with posterior segment settling with posterior segment surgeon, because we don't know what will happen intraoperatively. Cortical matter nucleus may go back, may have something posterior. Also to put a message in the mind of our friends and fellows, the trauma which will lead to subluxations or cataract may have an impact on the posterior segment, so we have to deal with and to keep the patient safely. And thank you.
Thank you, Dr. Mahmoud. Perfect job as usual. Place your hand. Dr. Salam, I think you have comments about these videos.
Yeah, I think really lovely videos. Thank you so much, Dr. Mahmoud. تسلم إيدك and shake your hand. I think my point really is that in the context of trauma, many things can happen to the lens. So, and I have cases where I removed the lens completely with the capsule and did not implant anything because everything really was very messy. And I thought this would be the best for this case, is to take everything out and let things settle down. And I had cases where I actually tied it up and left enough capsule to come back and put a lens in the sulcus. And I had cases where I tied it up and I left and I did a posterior capsulorhexis and I left enough lens and I came back a month or two and I put a one-piece lens in the bag. And I had cases where I put lens primarily in the capsule, in the sulcus, or in the bag. And I think really that's why trauma is difficult. Cases are not the same, and you may do different things really for different patients. So that's my only message. And I think the other message maybe is that the lens is secondary to the retina. So it's really like nothing bad that you don't implant now, and you can always come and sort this out later, especially with A scans being available. But if the condition is suitable, I think, yes, go ahead, definitely, and put the lens in the sulcus or in the bag.
Yeah, okay. Go ahead. Okay, go ahead, Dr. Rahman.
What's your preference, Dr. Salam? If you have not enough capsular remnants, we will go for iris glow or we will go for...
So I would not do the scleral fixation or iris glow or anything. There's no iris glow in the US. I used to do them in the UK. Right now, I would do anti-chamber IOL, or I would do aqueous 4-point scleral fixation. I've never done that many. I don't like it. I don't like the idea of it. But I would not really make things more complicated. I think if I can put a lens in the bag, which is my preference, or in the sulcus, I will go ahead and do it. Otherwise, I will come back.
Okay, thank you. This was my question about if you don't have REM, would you like to do more manipulation and procedure to implant scleral fixation IL? Especially, we have a different ways, different modes to fixate the IL sclerally. I actually love the glue with IL, but we don't have glue in Egypt, so I put stitch. That's the Agrawal's technique for the externalized haptics, and to bear both haptics on each side intrasclerally. But actually, it needs a well-formed tension to put it properly. So my preference to postpone the IOL implantation if you don't have a REM to put the IOL on. What's your opinion, Dr. Yassine?
So this is sort of my cup of tea. I had 3 cases on Wednesday, and I have 3 more next Monday. So I do actually a lot of secondary IOLs and sutured IOLs, and I do all of them. And generally speaking, usually what happens is really the IOL in cases of intraocular foreign body, usually it's coming as a case of trauma. You probably don't even know what your IOL calculations, probably it's in the middle of the night and you don't have all the facilities and whatnot. And this is the one time that I am happy to take the insult to Dr. Salam that the lens is secondary to the retina. So I agree with you that it should be, worry about the retina, worry about the foreign body, do what you need to do, and then The rest of it, we'll just have to deal with it later. And you can, if you feel comfortable with it, go back again. If not, just give it to an anterior segment surgeon who's comfortable with it. In cases who do really have complete pars plana vitrectomy, we have published a lot on iris sutured IOLs, and it's very elegant and really beautiful technique, and with significant stability. And we have follow-ups for by now for 10 years actually on these cases. The scleral fixation has actually increased in popularity. Basically, the AAO came out with the technology assessment back in 2003, showing that ACIOLs, iris fixated and scleral fixated, all of them, there is no clear superiority. And then people said, well, but now we have all of these new techniques because we have the Agrawal glued IOL, which is a fantastic, and Amar, dear friend, he really popularized it. And then Shane Yamani basically came up, and there are the modified Yamani. And with all of the data in the literature, including the aqueous, the AAO just came out in ophthalmology actually this past month, online, hasn't yet been in print. And
Dr. Yassine,
their conclusions are...
There is Ziada technique, it's coming, which is a mixture of all. Which is a mixture of all.
Okay, I look forward to that. I look forward to that. And in that case, the AAO showed that there is no difference between any of these techniques. So really, it's a case by case, and it's your preference. Like, for example, you're a retina specialist, you are very comfortable doing peritomies and sclerotomies. The aqueous is a reasonable thing. It gives you a lot of control. Your anterior approach from the cornea incision is very small. If you have the Yamani, you can do it through 2.75. You can almost do it through 2.4 if you do have the CT Lucia lens. And it works very well as well. So if a patient does have a really good iris, I do iris sutured IOL because it's quick, it's elegant. A lot of these patients with a trauma, they may need glaucoma surgeries in the future, so preserving their conjunctiva becomes very important to me. If the iris is not really that present, then scleral. And scleral, the Yamani, tends to be much less traumatic than the glued IOL. The issue, though, the glued IOL, I think your tunneling is a lot more controlled, and therefore there may be slightly less tilt. Even though the Yamani technique, when they published it, their tilt is less than 3 degrees according to their imaging studies. So in trained hands and whatnot, it can do very well. To make a whole lot, long story short, I have literally done hundreds of these surgeries, and I do them every week. And I do all of them. Each patient is different. Is the iris healthy? Does the patient has complete vitrectomy? How is the sclera and whatnot? And that would be the determining factor. So I don't really have a strong opinion of one versus the other.
Okay, thank you, Dr. Yassine. Thank you for all. Do you have cases of penetrating trauma to the eye with corneal entrance and injury to the lens without cataract formation? If you have an injury to the anterior capsule of the lens, and I think the posterior capsule too will be opened, but it's still sealed without escape of any of the cortical matter outside the crystalline lens. So if you have such case, will you keep the lens in place? Will you not touch the lens, or to do cataract surgery? What's your preference, Dr. Yassine? Yes. Okay.
Go ahead. Somebody wanted to say something, so go ahead, please.
Okay, Dr. Sallam.
I mean, yeah, true. Actually, we have a case of intraocular foreign body. Now we're prepping for surgery shortly.
Yeah.
So that's very interesting. And we were just talking about this point. So really what we tend to do is that if the entry is small and there's no lens matter in the antechamber, then we will conserve the lens. If the entry is big and there's a fluffy lens matter in the antechamber, then we will take the lens out. That's what we do. And then again, it depends. I may take the lens out and leave anterior and posterior capsule and then come back, or I may put a lens in, or I may take everything out, like I said. But small and no lens matter in the antechamber, I would probably leave the lens.
Okay. Do you think that this torn capsule will heal?
Yeah, and there's actually there are a couple of papers that show that it healed, and we see that as well with patients. It does heal, and it goes like a sectorial opacity. And even if it goes like a bigger opacity, it's much easier to come and deal with this later, or you can offset some of the astigmatism caused by the corneal wound. You also have better measurements for the IL power, and it's a much easier surgery.
Yeah, okay. Thank you, Dr. Salam. And thank you, Dr. Mahmoud, for you have done a very good job. Thank you very much. But my question about this image, I'm sharing it now. Do you see it?
Yes, yeah.
Yeah, okay. This is the stony foreign body. This patient was in my clinic the last week, the week before Eid al-Adha. This stony foreign body entered the cornea with the triangular valvular self-sealed wound, and then it's impacted in the angle, as you see in this yellow circle. This is the foreign body. Do you see it clearly? This is orange or yellow, and this is the entrance. So so the patient is blurry because of this opacity in the cornea. But this is the very mild ciliary injection at the side of the foreign body itself. But all around it's clear. What can I do just for the medical treatment and follow-up, or to do anterior chamber wash to remove this stony foreign body? What's your opinion?
To me?
Yeah, Dr. Khaleel.
Okay. In some literature, it is, if not doing a chemical reaction like cover, like iron, it can be left. But in some literature also, it is important to remove any foreign body entering inside the eye, because you don't know what is the complete nature of the foreign body. Yeah. So it may have alloys, it may have some metallic things and making reactions. So to me, it is important to open in it and to remove it using copious viscoelastics. I think it will not be so adherent to the angle of the eye. So I think it can be removed, and check if there is any other problems posteriorly.
What's your opinion about the eye? Is it quiet eye or angry eye?
I don't think it is so angry eye.
Yeah, it's just a sectoral injection. Yes. The side. It's completely stony. I think it's completely stony because this man is a worker in the mountain. In the mountain, what's called marble broker. So this is the marble or stone. I think the stone is inert or active or irritating one.
The stone is inert.
Yeah. So Dr. Salam, what's your opinion, to remove or to keep it in place?
I think I would opt for removing this piece of marble and maybe take it home.
Because of
it's a really marble. I think it's accessible. It's easily accessible, and also the eye is inflamed.
Yes.
And I don't think this would be a sterile, and I think he's lucky that he didn't get infection so far. I would advise removal.
Yeah. Okay. Even if the patient he may come 2 days after to the follow-up. If I found that the eye is quiet and this injection is not present, I will go for removal or to follow up away from the infection. There is no infection. There is no.
I would remove it. I think it's accessible.
Yeah.
It's reasonably safe surgery. I'll put my colon viscoelastic and pull it out. That's what I would do.
Yeah. Okay. Especially the marble is expensive now. Okay, Dr. Yassine, do you have other opinion?
In case of any complication, the marble is going to be a lot more expensive for the patient and the healthcare system. I think
Yeah.
anything that really does not belong in the eye, intraocular foreign body, it's a ticking bomb. So basically, and this is, it's really, the fact that you can see it from, just on the slit lamp very easily tells you that very likely just couple small incisions, you should be able to access this. And Dr. Sallam has a great point. Put the Michael to pull the iris away and just put a little bit of viscoelastic. The anterior chamber is going to be very well maintained. You go in, you take it out. It's not going to take you a long time. That way you sleep better at night and the patient sleeps better at night. And I think many times we have been burnt with assuming what nature of the foreign body is. Sure, he could be marbling, but there could be a lot of other contaminants that are with it. We have had somebody who came in with concrete, and in the concrete, there was actually, a little bit of a metal piece. And we didn't recognize that until after we removed it. And you keep it, you could have siderosis, you could have a lot of other problems, and then the complications can be much worse. So it's a small surgery. I would, in my mind, once I see that, I'm booking the patient for surgery.
Okay, great, thank you. So I'm asking all these questions because you know that the entrance of the eye or the opening of the eye is not easy thing. So we are saving it for the urgency, but I will think in this way to remove it, and I will feed you back. Thank you very much for covering this very important, crucial point in our daily practice. So we'll go back again to the medical problems with the diabetics, the uveitis. Not the diabetics, but with the cataract surgery with a chronic disease, especially the autoimmune disease, which is the uveitis, either anterior uveitis or posterior uveitis. Dr. Sallam, you are an expert in this field, so we are waiting for your guidelines about how to deal with the patients with active or chronic uveitis, acute or chronic uveitis.
Thank you so much. I can show some pointers, and then we can. I know Dr. Yassine has cases that he can show as well, the videos. So let me just share the screen.
Yes.
And just some pointers there, really. So is my screen obvious there?
Yes.
Okay. So again, preoperative consideration, control of inflammation. It's important to know about the pressure as well. Does this patient have high pressure, low pressure? Hypotony in uveitis is really very, very bad. In simple words, it's the end of the game in uveitis. And you don't want really to operate on hypotenuse side, because after cataract surgery, it will get more hypotenuse. And this is just the end of the game in uveitis, unfortunately. Then the other reconsideration is, does uveitis cataract surgery can cause reactivation of infection? And there's really mixed evidence. There's some evidence like from all cataract surgery that it does activate toxoplasma retinitis. And the Netherlands group suggested before, if you're doing cataract surgery in a patient like toxoplasmosis, give them prophylactic treatment. But that was at the time of extracapsular surgery. Mostly with phaco, it does not happen. You don't need to do prophylactic treatment. What if the patient had herpetic disease, herpes simplex virus? Again, thoughts from the herpetic eye disease study that might be best to give them prophylactic treatment for 14 days, 1 day before the surgery, and to continue after the surgery if they have had herpetic eye disease with corneal involvement previously. Special consideration in patients with Fuchs heterochromic uveitis and GIA. Fuchs heterochromic uveitis, they do very well with cataract surgery. They really do very well. Some issues happen after cataract surgery. For example, remember the classic teaching is they don't get to see synechia, they don't get pigmented capes, they don't get cystoid macroedema, they don't respond to topical steroids, right? That's the classic teaching for Fuchs heterochromic uveitis. After cataract surgery, these four things change. So they can actually get all that and they can respond to steroids if they have increased inflammation after cataract surgery. So it might be a good point really for Dr. Yassine to comment on Dr. Yassine, would you consider prophylactic treatment for patients with herpetic eye disease undergoing cataract surgery, a herpes simplex disease?
Absolutely. I think it's, and for me, that's, there are a few things we have to take into consideration. I totally agree with you that hypotenuse uveitis cataract surgery, very likely you're looking at bicycle eye. So
yeah,
you should not operate on an eye that is going downhill, and you should just, regarding the reactivation of infection, I'm assuming that you're going to come into how long the eye has to be quiet before you operate on it,
yep.
in a uveitic cataract surgery. Okay, so here, okay, good. Basically, especially for HSV, even if it hasn't been active, I don't operate on these patients for a minimum of 3 months, typically 6 months. And even if there's no reactivation, I actually put them on a treatment dose of Valtrex or acyclovir, again, starting orally a couple days before, and steroids, and I keep them on the Valtrex for those 2 weeks after the surgery, because we all know that the virus and the immune system is still there, and therefore the risk of reactivation is fairly high, and I don't really want to take my chances, so I always pre-treat those patients.
Yeah. So I think for infection, really the one to remember is herpes simplex virus disease. And also the point of hypothy. There's always really like zero tolerance for inflammation. These patients should have no inflammation, all the uveitis patients whatsoever for 3 months. I think yes, but it's easily said. And I think it's like the point really of controlling HbA1c before the surgery. Yes, true, we should do that. But again, it's easily said. The practical recommendation really is you want to operate on these patients when they have the least possible amount of inflammation. For example, if this is your patient and you've been following up, and this is the best thing you're gonna get ever with maximum control you can achieve in this patient, then this is the time to operate. Yeah. Ideally, no cells, but trace cells in this patient, and that's really what you really can get, I would operate. But again, important point is you have to try to reduce the inflammation to the maximum. Then there are really things you need to consider, and these adjuvant treatment range from topical steroid to periocular steroids to oral intravenous prednisone to intravitreal steroids up to really reticular at the time of surgery. And to cut the story short because of the sake of time, I'll tell you what I do. So if these patients did not have significant posterior uveitis in the past and did not have significant macular edema, then usually I would do topical plus or minus periocular steroids. But if they had macular edema in the past or significant posterior uveitis, then this is really too soft. And I would go down the line to one of these. Usually, if there's no documented hypertensive steroid response, I would go for intravitreal therapy. I think it's nice, it's elegant, I really like it. If there has been, or it's a single eye patient, then I would go for oral intravenous prednisone. So I would start them oral treatment a few days before the surgery and continue for around 2 weeks after the surgery. And with one thing, maybe a good point, if you keep a patient on oral steroids, even if it's a high whacking dose, you can just stop it. You don't need to taper it. 2 weeks, you can just stop it. And that's what they did before the optic nerve treatment trial. So you can give them a 2 weeks period and just then stop it, even 60 milligram a day. So that's what I tend to do. And then I think the points for discussion, Ria, maybe Dr. Yassine would show us videos on that. Again, same points we discussed there. Pupil management. So you need to make sure you're comfortable to operate on. Capsulorhexis, again, for viewing. Also, they are high risk of capsular contracture syndrome. I'll do what Dr. Ziada said. I try to keep the AC stable in Uveitis diabetic patients, or if I have an anterior capsular tear or a posterior capsular tear, which means that every time I would come out of the eye, I would place viscoelastic. So at all points, the AC would remain deep. And I would hydrate the wounds before removing the viscoelastic at the point. I don't want the AC to collapse. You're really like damaging the blood aqueous barrier more. And then we talked about periocular versus intravitreal treatment. So that's what I do in uveitis patients in short.
Okay, perfect. Dr. Sallam, thank you for this yeah, stepping display
Nice.
about that.
Very, very nice.
Yeah, very nice, and stepping and high guiding protocol to deal with. But actually, all the patients with uveitis should be put under the preoperative steroid therapy, or the very old patients with the last attack more than 1 year. Would you operate without preoperative, just intraoperatively, just intraoperative steroid, and then frequent postoperative steroid topically? Or
yeah, they are all going to get hourly steroid drops. Also, all uveitic patients will get hourly steroid drops and then go 6 times a day. So, but if they have had posterior disease or CME, then this is too soft, topical or periocular, and I would go either systemic prednisone or intravitreal steroids. If they have not had that, then I would use topical plus or minus periocular steroids.
Yeah. Okay.
There are a couple of things.
Yes.
So there were 3 major trials with uveitis, not with cataract, but with just uveitis and macular edema. There's the MUST trial, which is the multi-center uveitis steroid treatment. There's the POINT trial, which is the periocular versus intravitreal corticosteroids for uveitic macular edema. And there is the macular edema ranibizumab versus intravitreal anti-inflammatory therapy, which is the MERIT trial. The POINT trial basically shows that intravitreal corticosteroids are superior to periocular corticosteroids. And the rate of substantial elevations of the pressure were low and the same among 3 groups. We were always worried that, okay, if I give a lot of steroids, if I give intravitreal corticosteroids, I'm going to be dealing with a glaucoma and whatnot. But really, actually, in the POINT trial, it was pretty acceptable. And the last thing that they actually looked at was the intravitreal dexamethasone implant, and it was non-inferior to the intravitreal triamcinolone. So you do have the option in patients who you're really worried about, and as Dr. Sallam said, you still have a little bit of low-grade inflammation and whatnot, and they have had a history of macular edema from their uveitis. It's a really good idea to consider intravitreal injections at the time of the cataract surgery. Interestingly, we actually submitted a grant to the NIH, which is the PROTECT trial. Hopefully, we'll hear something positive about it, to see what would be the best option to control the uveitis at the time of cataract surgery. So hopefully that will be coming in and starting recruitment sometime in the next year and whatnot. So that is one thing that we are working on. The MUST trial, basically, systemic approach is really good as well. So what I do is what Dr. Sallam did, just start them with oral medications, 60 milligrams, and you are not going to adrenally suppress them if you're just going to do short, steroid dose. So start them with 60 milligrams for 2 days, 40 milligrams for 2 days, 20 milligrams for 2 weeks. That's what I do. But you can do whatever tapering works for you depending on the patient. And then hourly or 8 times a day steroids after the surgery is a very reasonable thing. And then you will really have to look at these patients closely and monitor them closely. Usually I do steroids and ketorolac, for example, for 4 weeks, but for uveitic patients, I'm very likely to extend it. So I'm going to have very slow taper of the steroids versus the average patient, so that to prevent relapse, inflammation, and iritis. Those are the major things. Now, that is the medical management. And I have to say that these patients are probably tend to be some of the most difficult, not because of the surgery itself, but because also of the management of what happens before and afterwards. I'm having a hard time actually probably sharing my slides. Let me see.
Maybe because I need to come out, I'm not sure.
Okay, let's see.
One point as well, even in the MUST study, there was an ad hoc analysis of patients with macular edema, and actually Retisert was more superior than systemic treatment for those patients with macular edema.
Yeah.
It seems local therapy is even better for macular edema.
You're right that for the first 5 years, the implant actually did better. For the first 5 years in the MUST trial, the implant actually was better at controlling inflammation. At 7 years, the systemic approach was actually a little bit superior because there was a little bit of retinochoroidal damage, partially due to the implant. And there were actually the systemic therapy from the MUST trial had no increased risk of systemic side effects, except that these patients had a greater use of antibiotics. And it wasn't clear what their antibiotics was. Is that because low grade or low threshold for the primary care doctor to start the antibiotics, considering these patients were immune compromised, or that they had really higher susceptibility to infections as well? And that remains to be decided. Lastly, the implant itself was associated with increased risks of cataract, which is, we know that it's universal. Interestingly, patients with uveitis, they have cumulative every year 7% increased risk of developing a cataract. So we know you are going to see these patients. So no matter what, they will be dealing with that. Do you see my screen or no?
Yes.
Okay,
Yes,
so
yes, we can.
let me just
It's not for.
So as Dr. Sallam basically said, if IOP is less than 6, I am calling it quits. I'm not really operating on that patient. If the patient does have inflammation, but they are developing seclusion pupillae, I am much more likely to operate even though the inflammation is still there, because I am worried about that patient. You have to be careful that these patients also can have zonular donesis. Now let's talk about what you guys do at the time of the cataract surgery in regard to the iris. We talked about the pre and intra and post treatment of the inflammation. What do you do regarding the synechia? What do you do regarding the IOL? Dr. Ziada, I'm throwing the ball in your court.
Excuse me?
What do you do regarding your iris handling, in these uveitic patients?
Yeah, okay. During the surgery with such patient, I will dissect using the viscoelastic. I think I have to have posterior synechia with the anterior capsule of the lens. So I will expect that there is a lot of the calcification of the anterior capsule with adhesion with of the iris, especially the pupil with the anterior capsule. So I will go thoroughly and carefully with the viscoelastic, and then try to dissect and to remove this adhesion very, very smoothly and carefully, not to tear the anterior capsule, and also not to trigger the iris. Then I will put at the end my the iris hooks to dilate the pupil, which will be irregular in most cases. I have a case. I may show it at the end of your presentation about how to deal with the iris in such situation.
Go ahead if you want to show it, because the video for me is not playing for some reason. So let me just take that a little bit. If you want to start your video, that would be fine.
Would you try? Do you like to try again?
Well, I can actually get it from another place. So yes, just give me a second. So I can probably do this. Here we go. So this is actually a patient with HSV keratitis and uveitis, and basically ended up having a severe ulcer with superinfection. The patient has already had a PKP, and you look like it is decentered because they actually ended up having fungal ulcer on top of the HSV keratitis. And now the patient comes in with almost actually 360 seclusion pupillae, and you'll see that you have to break down the seclusion pupillae and the fibrotic membrane, and you'll see that sometimes you have to have multiple approaches in these patients. We started with viscoelastic already in the eye, and now with just iris sweep, I'm trying to actually break down the posterior synechia. This is a very old video. This is, I think, something like 7 years ago. And you'll see that you have to be gentle and you have to see where you are going. And here is the fibrotic membrane. So you have to dissect it from the lens, and you have to be very mindful. As I'm doing it, I'm actually pushing a little bit up. Once I do that, then I actually, in this patient, I'm much more likely to use iris hooks because of a lot of issues. Sometimes, if there are zonular problems, I'll actually put the hooks into the capsule as well. Some people use capsular tension hooks and whatnot. I use that. Then you want to be very thoughtful about your capsulotomy. These patients will end up having a little bit of phimosis. So you'll see me going out a lot more. And of course, the surgery is a little bit challenging because you do have that edge of your, of the cornea transplant right in your surgical field. So you just have to basically trust your gut and just go right around it and outside of it, even though you can't see it. You just have to be able to manage it and do the capsulotomy. I would have usually used actually trypan blue, and I usually have very low threshold to use trypan blue in these patients. But the membrane, we couldn't get the trypan in, so I was like, okay, well, we can still do it, and I feel comfortable doing it. The second thing is a little bit gentle hydrodissection to actually prolapse the lens. And now with the phaco piece, you just come in. I actually pop and chop most of these lenses, as I do with pretty much all of my cataract cases. And I use hooks in this case because it allows me to figure out where my axis is. You can always elect to put one more hook right here, and that could actually improve your visualization of the surgery. And then you just to bring it up and you are cracking the lens. I try to operate a little bit more anterior than normal in these cases so that I'm not I'm not increasing the risk of macular edema. You have to be careful with this technique in the sense that your endothelial cells can suffer in the process. But you can see that I'm pretty parallel to my iris plane right here and right at the iris plane. Basically, the lens goes out and then I do the IA. This is actually almost real time that we are working on. And now you just put viscoelastic Provisc in, and I always use a 3-piece in uveitic patients unless there's an indication for something else. So here I am inserting the 3-piece IOL. I invariably leave the haptic outside, and then I just basically just with one step dial, and it is in the bag, and your surgery is done. The hooks can be really, really helpful in this patient scenario because it just makes the surgery back to normal. And the way I usually now remove my hooks, it's just one-hand technique. You just go in and you push it in a little bit, and then you bend your hands down to release the hook from your iris, and then you just push it out. So that's just one way to do it. The second surgery, this is the same thing. It's a uveitic patient, and you can see that the patient does have a little bit of synechiae, not as extensive as the other patient. And we start again. I really like to start a little bit of trypan blue in most of my uveitic patients because it also allows me to see the edges of because of the poor dilation and zonules. It allows me to have a really good capsulotomy that I can rely on. Worst case scenario, I can always put a sulcus IOL. So for that regard, I can do that. And some people may start the trypan blue before breaking the synechiae, which I tend to do. And sometimes I would go actually underneath the iris and put some of the trypan blue. What you have to deal with is the trypan blue will be stuck even after you put your whatever you are washing the trypan blue with, including the visco. Some surgeons will go break the synechiae before they actually put the trypan blue. Either is fine, whatever is convenient for you, whatever you are comfortable with is fine. To break the synechiae, I usually would go to an area that doesn't have synechiae yet, and I would start because that gives me a space, and then I work with my space. And sometimes you have actually, with viscoelastic alone, you can break it. I have to go back to the first video after this to show you that sometimes no matter what you do, you cannot break it, and you have to do actually push-pull technique of breaking down your synechiae as well. This patient does have an okay actually iris size to do the capsulotomy, but the iris itself is atrophic, so I was worried a little bit about the floppy iris at the time of my surgery. So actually, I go ahead and I use a ring in this case because the rest of the eye is behaving normal, and I just basically get my ring in, disengage it, and then it becomes a routine cataract surgery for this patient. So I start my capsulotomy. And I usually just now start my capsulotomies just with the Uveitis. I don't really use the cystotome anymore. I just basically puncture my capsulotomy with the Uveitis and just go in. And I like to have, this is a 7mm Malyugan ring. So my capsulotomy here is about 5.5 to about 6. Even with 5.5 or 6, you can actually be able to prolapse the lens. My favorite technique is pop and chop. With the pop and chop, it's a little bit harder to do with the Malyugan ring because the Malyugan ring is going to try to keep your lens back. And that's basically, I'm just finishing up with my capsulotomy. And these, and then you just basically put a little bit of BSS. In order to pop it, you don't want to go across, you just go a little bit subincisional, and you just a tiny bit of wave, and you can see the lens just coming out. You really use less than half a cc of BSS to do this, so it's not that difficult. In Malyugan ring especially if you're starting, I would put viscoelastic to protect your capsule so that the capsule is not coming at you and the lens is far from it. I finish my my phaco, and then I just put my IOL, and then I take my Malyugan ring out. There are multiple ways to take your Malyugan ring out. You can actually either dislodge one and then bring your Malyugan inserter in and just engage into one of the eyelets and bring it out. Or you can basically start 180 degrees away and dislodge this one and then rotate all of them out. Whichever way works for you is fine in these cases. This actually, I think I was struggling with the iris in this scenario right here. So let's go back to the synechii with the membrane. And you'll see that I'm trying to break, but actually the membrane is everywhere. Not only is it synechii, but the fibrotic membrane is just keeping my iris, basically my pupil really small and together. And I'm putting a good amount of stress in this case. So I go ahead and I put a little bit of viscoelastic to help me with dissection a little bit. And you'll see that even with that, there's still that I'm trying to get rid of this fibrotic membrane. Then you can use actually bimanual technique to remove them. So that's in a nutshell with the OR that you have to worry about in uveitic patients. Mostly, sometimes the synechia is a lot worse. Regardless, with the new techniques, with iris hooks or Malyugan ring, you should be able to do either, and you should be able to satisfy that. One of the reviews that I thought that was reasonable and for beginning cataract surgeons is actually a review article that was published in 2012, which is Cataract Surgery in Uveitis, and it goes over these things. It's from the LB Prasad in India, and it goes over these things in a good way. So those are the points that I wanted to do as far as intraoperative. I'll leave it to the rest of the panel to make comments.
Okay.
Yeah, do you have any comment, Dr. Mahmoud?
Yeah.
Yeah.
Okay.
Fantastic surgery, beautiful, Yassine. That's fascinating.
I
do more or less the same. One thing I started doing now is that if there are pupillary membranes that I don't need to remove, I leave alone. Just like the more you do in uveitis, you learn that everything you do comes and bite you back. So sometimes I would just like cut the membrane into two with a scissor and get it to open, and then put a Malyugan ring and then just trim it afterwards. But I wouldn't peel it anymore unless I have to peel it. It's just uveitic eyes are very fragile eyes.
Great video and great management, Dr. Yassine. Dr. Mahmoud, yeah, you have a comment. Yeah, okay.
Very, very nice surgery, Dr. Yassine. My question, what is the preference of the IOL? Acrylic IOLs, hydrophilic IOLs are good for the uvea, but less good for the posterior capsule. Hydrophobic IOLs is good for posterior capsule, but less good for the uvea. What is your preference? Hydrophobic or hydrophilic IOLs?
I think there's a lot more talk overseas about hydrophilic versus hydrophobic. And in these cases, really, I still use the hydrophobic. The more important part for me is really regarding the IOL is the sizing and the diameter of the IOL rather than the type of the IOL. And I like to have a large diameter IOL in general, because I know that these patients are going to be complex. I know that, you know, in the future there's something they could, they have a much higher risk of developing membranes, developing capsular phimosis and whatnot. So the more tension that I have actually with a 3-piece IOL diameter of 13 millimeters, the less likelihood, you know, that capsular phimosis is going to happen, or, you know, future IOL dislocations and whatnot. But I don't have a type of, you know, hydrophobic or hydrophilic in regard to uveitic patients. To my knowledge, there has never been a study comparing hydrophobic and versus hydrophilic lenses in uveitic cataract patients. I'm not aware of that.
Okay.
There
Second
are
question.
preferences, but there, you know, and there's expert opinions, but that's
Nice.
not really evidence based.
Nice.
There's one Yassine actually from Morphos by a friend of mine called Mustafa Al-Gohari and Sue Lightman. I think it's slightly a little bit old. It's in 2005. And I can't remember really their conclusion, but I think they more like for hydrophobic. And they looked at uveitis and PCO. I'll try to look it up as we speak.
We published a paper in 2007, 2008. But it was mostly in children, actually. It wasn't, it was uveitic cataract surgery in children. The greatest predictor about it really was more of the, how the uveitis was controlled pre-operative more than the lens. But I would be very interested to know what that paper says.
Okay, thank you, Dr. Yassine. Really, I didn't comment at the end of your surgery because I'm waiting for more of your great and amazing videos. So I didn't know that you have finished that, your videos. But let me to complete the story you have started, but in different and attractive way. And in this case, I had a boy who was 6 years with an old, a long past history of uveitis with complete, with the seclusive pupillae and dense white cataract. The vision on presentation of this patient or this boy was light perception, just light perception. So the parents told me that they came to my clinic at the last station or at the end of their tour, searching for a solution for their boy. Because a lot of surgeons before refused totally to do anything for this eye, and they are saying all the time, nothing to be done for this eye, and may Allah keep the other eye. I don't think that this was right, because this patient is still seeing light perception. And the light perception means that the hope is still present. So there was indefinite diagnosis and treatment about the cause of the uveitis, but there's marked decrease done to the visual loss of the eye, but the other eye is completely okay. The right eye is light perception, but the other eye is 6/6. I think my screen is full now, right?
Yes.
So on examination, the right eye, the intraocular pressure, and this is the point of hypotony, Dr. Sallam, Dr. Yassine mentioned, the intraocular pressure was 16 with the applanation Goldman tonometer. The other eye is 15, almost the same. Anterior chamber clear but totally irregular, with a very unstable relation between the iris and the anterior lens capsule. While the other eye is clear, the pupil, exclusive pupillae, the other eye 3 Rs, the lens white cataract with a calcified and regular capsule with brown staining. Elsewhere, the other eye is clear, the fundus not seen. So I asked it for ultrasound, but the other eye was completely normal, anterior and the posterior segments of the other eye. So it was a strange case. The ocular ultrasound showed that the posterior segment is completely normal. There is no vitreous opacities, and the retina was okay, but unfortunately, I don't have it now. But I asked for the VEP and ERG, the electrophysiological studies, I told the parents that I'm not sure about the post-operative results of the surgery, but I have to think to do it. But I counsel them that it's just a trial as a chance pre-operation with a very guarded prognosis. I will be guided by the VEP and the RG. If they are okay, I will go for surgery. If they are not okay, I will not go for any surgery. But surprisingly, I was the first one to ask for the VEP and ERG, not asked by any other surgeons. But fortunately, I found that the retinal function is mildly subnormal. Sorry, there is mildly subnormal function of the visual pathway, but with very good function of the rods and cones. I think it's encouraging to do the electrophysiological study as well. So I have done this case. As you're saying now, it's occlusio pupillae, but with quiet anterior chamber. So I placed my incisions, preparing for the iris hooks. Then I entered with the spatula to dissect and to open gently and carefully. Then I put my iris hooks. There is no role now for the tree-band blue staining because there is no opening in the pupil to stain. And as you see now, there is heavy pigmentation of the anterior capsule of the lens with calcification and adhesion elsewhere. I tried again to stain the capsule after opening the pupil, but unfortunately the viscoelastic was an insulator between the stain and the capsule. I tried to do the capsurexis. My capsurexis was so difficult because of the calcification of the capsule and the irregularity. But I did my best to get an incomplete rexis, but helpful one. Finally, I have around of 2/3 of the capsurexis, and the remaining part was completed as a can opener. Fortunately, the cataract was not dense, was friable because in very young age. So I did no effort, I did no effort to aspirate. Yeah, the hydrosection of the fluffy material, they came up. Then by the irrigation aspiration, there is no need for the hand piece. So I entered immediately with the irrigation aspiration and aspirated all this white matter. And because I was dealing with a boy, with a child, so I have dealt with as a congenital cataract. So I plan to do the posterior capsurexis to avoid the posterior capsular opacification together with anterior vitrectomy. Then after completion of the IA, I inflated the bag and then did my posterior capsulorhexis. Yeah, the enhanced retroflex to help me. The capsule was elastic, but was behaving like that of the uveitic patients and with the congenital patients as well. So I tried to do it idly as I could, but it was not easy, but finally done. I have implanted, in this case, a 3-piece IOL to be sure about the support of the haptics. Especially, I don't have regular anterior capsulorhexis and posterior capsulorhexis too, so I was in need to more supporting IL, supporting haptics of the IL. So I implanted the 3B switches, which was moving its way to the posterior segment. You know that the haptic, I think the haptic all the time likes to div down. I don't know why.
And when you want the lens to goes down, it doesn't goes down.
Yeah.
It does not go down.
Curious haptics. So this rigid haptic was going down. So I entered with the spatula to put it again up, to bring it up again in the bag. Yeah, and then completed the push. To know, I started 2 weeks before surgery with just prednisolone topically. There is no systemic treatment for this patient. Pre-operative, so I was asking about if it's mandatory or not. Yeah, I removed with one hand, like Dr. Yassine told me to do. Then I washed the anterior chamber with the pupillary plane, washed all the visco material, and then hydrated the wounds and injected my. I was keeping the anterior chamber inflated all the time, even during the stromal hydration of the bones, not to have a collapse of the anterior chamber and tilting of the IL, because I am worried about its drop. And finally, injecting the my lovely air bubble. I love to inject the air bubble at the end to support the IL, and finished the surgery. So we were waiting on a fire for the post-operative result of this procedure. The unaided was surprisingly 360 at the first visit, 3 days after surgery. Then after 2 weeks, 660. After another 2 weeks, 624. And the last visit was 1 month ago. The unaided visual acuity was 618 after 2 months from surgery. The anterior chamber inflammation was severe at the first days after surgery, but decreasing with usual topical treatment, no systemic treatment at all. The anterior chamber reaction went down to free and clear anterior chamber, but with very faint pupillary membrane, as you see in the photo above. This pupillary membrane, after a time, with a small dose of non-steroidal and fluorometholone, it completely disappeared. Now the anterior chamber and the pupil is clear now, with no need for any systemic treatment and with no need also for any YAG capsulotomy. But the posterior part of the capsule, sorry, there is a laser membranectomy. I mean, the posterior part of the capsule, there was at the edge, there is some membranes or some opacities, which I have removed by the YAG laser, but not for the anterior membrane because it's not quite accurate to do it. The unaided visual acuity is 612. So they were so happy, and I was too. They came to celebrate. They came to celebrate the success of this operation around my clinic. So the home message, not to cut the hope. If you find a very small opening for the light, you have to widen it, not to close it. And thank you very much.
Nice.
That's beautiful. Thank you so much. That's really beautiful.
Thank you, Dr. Salem. Thank you.
I have just one comment.
Yes.
Dr. Hassan, when I have vitreous opacities, I make also posterior capsulotomy, but with the help of the trocar. I finish my work anteriorly and insert a single trocar and make irrigation from the sideboard, and then making a capsulotomy with the cutter after insertion of the IOL, and making anterior vitrectomy and keeping more patient to remove as much as possible as from vitreous opacities. and I feel it makes the life better post-operatively, less post-operative vitreous inflammation, less post-operative no post-operative capsular opacification. So it making the uveitis more quiet.
Okay, you mean intraoperatively at the same session after implantation,
but not posterior capsulotomy with the
anterior approach.
with the cataract, with posterior approach.
Yeah, you mean posterior approach.
Barzoplana approach.
Okay.
With the trocar.
But it would be regular and controllable like that of the anterior approach.
Yeah. With the good parameters of cutting for 400 vacuum 400, and making an onion like spiral rixes, you can get a good circular posterior capsulotomy. Looks like doing it anteriorly.
Okay, thank you, Dr. Mahmoud, for this this good note. I thought about it. Yeah. Okay.
That was a beautiful case. MashaAllah alayk, يسلم عليك. يعني that's a great case, and it's very talented, and it's really wonderful to see that we have such a skill in the Middle East, which is really great.
Thank you very much.
I think capsulotomy, posterior capsulotomy, you can do it either way. If you feel comfortable with pars plana, it's great, but doing it anteriorly is fine. I actually do some of these cases with retina in case, and sometimes the retina guys feel it just for them it's natural to do pars plana, so they just go ahead and do it. And for us, we are always used to doing just the capsulotomy, at anterior, so we just pretend it is anterior capsulotomy and we do it again. And both are reasonable. One of the concerns is, you're right, if there was a vitreous to break, then you will have to rescue yourself, with a vitrectomy. It depends in these cases how long the inflammation has been. If there's a lot of inflammation in kids, especially, our recommendations had been that if the eye is not quiet, to leave the patient aphakic for a while, because the IOL tends to actually be a little bit, it can cause a little bit more inflammation than needed. Patients that we left, when I was at Mass Pioneer, patients who we left aphakic versus the ones who we put a lens in, ended up having better visual acuity in the long term. Even though, like you can go back for a secondary IOL or whatnot, or a contact lens, it works very well. But if the eye is quiet for 3 months, you can put an IOL. If it is not, I usually may leave them aphakic in these cases. I don't know what the other, Mahmoud or Ahmed, what do you guys do?
I think really it's a great point, and I think it gets us back to the point where it's not bad leaving the eye aphakic, and I would do exactly what you said. And really, this is my experience as well. The other points, really, I think it's a great case, Dr. Ziada, and it's really beautiful case, and I really like doing the Capsulotomy with the forceps. I think it's a great practice. And I like doing that. If it doesn't work, then I will go from the back. But I think it's a good skill to have. A few things I may do in uveitis in general. I monitor the patients post-operatively. If there's start of fibrin, I like to use intracameral TPA. Mm-hmm. It's fantastic when the fibrin is really getting bad, and it dissolves the fibrin in 20 minutes. We do that, not a lot, but when it's there, and it works like magic. The other thing I do, particularly if the case 3, like your case, is I put intracameral dexamethasone. I put it away from the cornea, and I put the same dose we do for vitrectomy, which is 400 micrograms, and I put it away from the cornea. I have the feeling that it keeps the antechamber quiet. I mean, I don't think there are good data on this, but that's something I do as well. So okay. Even if I'm going to do intravitreal Ozurdex, I still at the very end do intracameral dexamethasone.
Okay, thank you, Dr. Sallam. Thank you for these good points. But actually, we don't have a preservative-free dexamethasone.
No, it's not preservative-free. It's not preservative-free.
Not preservative-free?
No, it's intracameral.
I did it in Uveitic patient, and I did it in vitrectomy and diabetics. I did it routinely. Yeah. It makes it lessens the post-operative inflammations in vitrectomy, even in diabetics.
I try to put it away from the cornea. We use the standard.
In this case, I just injected subconjunctivally triamcinolone. at the end of the surgery. And it was so helpful, in my opinion, to avoid the systemic therapy, which is not controllable in such patients because she's almost away from me in the follow-up, during the follow-up. Actually, I may consider Dr. Yassine, you know, Kamran Reyes. Yeah, okay. And his work about the intravitreal injection of both moxifloxacin and dexamethasone intravitreally at the end of surgery.
You mean like dropless cataract surgery?
Yeah,
just
dropless,
routine.
yes. In the regular cataract surgery, and it could be helpful and beneficial in such patients. Yeah. There are a lot of techniques to do in such patients. Thank you very much for your for your tolerance. I know that you are exhausted, more than 2.5 hours. You are sitting in front of your PCs. So, but I tend to squeeze the experts all the time. I tend to squeeze the experts to take their notes. Dr. Hosni Hassan, my professor, is sharing his screen now. So, I'm sorry. So I want to end this great meeting with a question about the combined phaco-vitrectomy to close. If you have just 5 minutes to cover this point, just your opinions about the presbyopic patients. If you have a presbyopic patient beyond the age of 40 with a vitrectomy, would you do phaco even if there is no cataract in such patient or not? Starting from with Dr. Salam.
So patient having diabetic or in general?
I missed it.
So, in diabetics or in general, you mean?
Yeah, both of them. Starting with the diabetics.
Right. So just something that was found before, and we had like published from a big data on it. We found that diabetic patients after vitrectomy, interestingly, they get less cataracts than non-diabetics. It was thought that the blood sugar around the lens is protected, but actually it's the oxygen tension. So it's actually interesting, like diabetics get everything bad, but after vitrectomy, they get less cataract. With that being said, what we try to do, if we think that the surgery is not going to be so long and the lens doesn't have like significant opacity, we just do the vitrectomy. If the surgery is going to be an extensive 4 hours delamination or the patient has significant opacity to affect our vision, then we will do combined surgery. And I do cataract surgery, so usually me or my fellow will remove the lens before the surgery.
Okay, thank you. Dr. Mahmoud, what's your opinion?
Yes, I like Dr. Ahmed Sallam said, I don't prefer to do phaco unless I can deal with the posterior segment efficiently. So I just did vitrectomy. I leave a time for PRP to make the posterior segment more quiet. When the cataract is significant, when I did phaco-vitrectomy, I faced multiple problems of post-operative inflammation, post-operative membranes, up to iris Bombay, which makes the life is more difficult. So I just did vitrectomy. Unless I can see, I will do phaco-vitrectomy. I will at the end of the surgery, I will inject dexamethasone intracameral, and I will put the patient in systemic steroids for the first few days to control the post-operative inflammation. This is my my opinion in this issue.
Okay, thank you very much. But I mean, with the cataract removal, that some surgeons may think in removal of the lens, because they will remove with a silicone removal, because almost all cases with silicone will get a cataract, complicate the cataract to silicone. So when they remove the cataract, they can deal easier with the peripheral parts of the retina, especially in the large and myopic eyes. Do you believe in to do peripheral shaving properly at I'm not a vitreoretinal surgeon, but Dr. Mahmoud knows that I'm liking to visit the posterior segment after
from time to time,
every other month. Yeah, not to mess it away to the posterior segment, but I may feel difficulty in dealing with the peripheral parts of the cornea because I'm worried about touching of the lens and getting cataract in the first week after surgery. So I cannot be on this point because I'm not expert in this way. What's your opinion? The lens may interfere with your work peripherally.
Okay. Cortical cataract, it makes difficulty in shaving, in doing peripherally, but you can overcome this with doing injection. Lessons in making injection, you can go so peripheral, a good, somewhat good peripheral view, so you can go for shaving and for doing laser. If you're feeling annoyed, if you're feeling you can't reach the periphery, if you think you are not, you will not do your job completely, okay, I will go for cataract extraction.
Okay, but it's prior decision. You will not stay. You will not wait. Yeah. Okay. You know that we have conducted paper with our senior vitreoretinal consultant about this issue, and we have found in results as the combined surgery provided easier surgery peripherally, increased the visual improvement, the incidence or the percentage of the visual improvement because of the decreased incidence of getting cataract after the surgery, because they are presbyopic, so they will need the reading glasses after there is no need for the crystalline lens, and both are equal in the recurrence rate. There is no difference between both techniques. Separate just vitrectomy or combined surgery about the recurrence rate in this. Just the easy procedure intraoperatively. Just do you agree for that?
Okay, the issue is the post-operative
and don't worry about the senior.
It's the only issue. the issue is in the post-operative inflammation is good, and you have a post-operative inflammatory membrane, you have iris Pompeii, you have bit IOB, you have optic nerve, compromised optic nerve, you have lost the vision. So it is the issue. I have to control the posterior segment at first, and when I go for phaco later on, I know I'm not faced with any complications in the future. So it is the issue of post-operative inflammation, which is present in diabetics more in non-diabetics, in thick vitrectomy.
Okay, I think Dr. Salam will agree with me about the complication. Yeah. Just a second, Dr. Yassine, about the complication of the intraoperative complication from doing cataract with vitrectomy, which is the pupil constriction and the zonular dehiscence, which may be a route for silicone escape to the anterior chamber. Am I right?
So again, I think this is a great point. I use silicone oil minimally, really, especially in diabetics. I try to avoid it. You get retro oil proliferation, and all the very nice delamination that you've done is really lost because of the retro oil proliferation. So the general teaching in the UK where I train and also in the US is really like you avoid silicone oil in diabetics. So we try to use gas more. And I'm not aggressive with shaving, so I do agree what's required. I'm not really like obsessed with shaving everything. I try to do like Mahmoud said. I leave the cataract. I believe less is more, especially in diabetics and in uveitic eyes. So I try to do the least I can, really.
Okay, perfect. Thank you, Dr. Yassine. I think you have comment to say.
So I don't know the posterior segment, of course, as much as our esteemed panelists, but I actually have a full day a month that is dedicated for combined surgeries, cataract and vitrectomy with my retina surgeon, where I do the cataract and they do the retina surgeries. And then at least 2 or 3 other combined cases a month, that are scattered. So I would say I do probably roughly anywhere between 8 to 10 a month combined phaco vitrectomy. And that's only me, and there are other providers. We looked at our data, and actually in our data, the combined surgeries ended up doing better over the long term. And we're looking forward to publishing that data. And it's a pretty big stat because I've been doing it for about 10 years. So we have a few hundred patients in that case. Generally speaking, it hasn't been my experience as much as Mahmoud that the inflammation or the iris bombae is significantly worse in combined versus just vitrectomy. But I haven't looked at it from the vitrectomy side of things regarding the inflammation really. So I'll get back to you on that, hopefully sometime in the near future. But with my surgeons, we have relatively low threshold to do a combined surgery in these cases. It just makes the patient's life better. It makes everybody better. You don't have to bring the patient back to the OR twice. You don't have to, post-operative management twice and all kinds of things. So it's for us, it just logistically, it makes a lot more sense. We really haven't given it a serious thought that, do it, sequential. Of course, if there's something you have to go with the vitrectomy, you have to do it. But if most of the time, we prefer to do it combined, actually.
I think one point, Yassine, is that epiretinal membrane surgery, for example, or macular hole is it's a different ball game from, even primary retinal detachment, which is a different ball game from complex diabetic detachment. So I think it depends also what you're dealing with, really. And whether you put gas or not, that's another factor. Gas increases the risk of lens decentration and iris bombae compared if you left the eye fluid filled.
Yeah. Well, hopefully Hussam can actually invite us for another session because I actually have another meeting in a few minutes. Yeah. But then we can actually talk about what to do from the cataract in case you are doing a combined vitrectomy and how you can manage those issues. Because I think those would be great for us to think about.
Yeah, and for dinner as well.
Okay. Okay. I have already planned to finish now because I see you exhausted and hungry now, I think. And
I'm going for an intraocular for.
He's going for.
I have my fellows.
He just got paged.
We'll do what I just learned from Mahmoud.
Okay, thank you
so much, Dr. Ahmed. I learned so much from Dr. Ahmed and Dr. Yassine and my senior Dr. Hussam.
Thank you very much.
We learned so much.
Thank you guys so much for having us.
Thank you, my special friends and my special brothers and colleagues, and also my teachers. Thank you, Dr. Yassine, Dr. Sallam, and Dr. Mahmoud. And also really the discussion and talking with you is not stopping, and it's a way with experts everywhere. Thank you very much for your time, and we will arrange another meeting to complete this topic. And thank you very much, and may Allah accept your time and your knowledge. We have learned it a lot from all of you. Thank you very much, and have a good night, Mahmoud, and have a good day, Yassine and Sallam. Place your hands, and special greeting to all audience, and special greetings to my professors who are attending the meeting from the start, Dr. Mahmoud Abdul Badia and Dr. Hosni Hassan, my great professors in Azhar University. And thank you for all. Assalamu alaikum wa rahmatullah wa barakatuh.
Wa alaikum assalam wa barakatuh.
Yeah, Baisha, and you did fantastic.